So Corona, one thing of this Corona time that's really given us the opportunity is the opportunity for us all to meet one another as doctors virtually. And I've really felt that one of the real pros of this time has been the real interplay between different sectors in the healthcare industry and different organizations, doctors and people who otherwise wouldn't come together, particularly the huge close cooperation between the private and the public sector. I mean, I remember at the height of this pandemic, speaking to Dr. Freeland, who's with us tonight, who I'll introduce soon, and how he so graciously said that, you know, the private sector was there behind public patients who would be left in trouble. And we saw so much how the public sector reached out to, obviously, as they would, all South Africans, and was ready to educate and grow and build the whole community. And this is such a heartwarming thing for us as doctors, because wherever you work, I mean, we're all here for common goals. So once again tonight, the reason why I bring this up is I've chosen to start off this meeting, which is largely a meeting just for, firstly, primary healthcare doctors, but secondly, we're very thankful to have all the specialists and allied people who have decided to join us with us as well tonight. Start off the meeting with a very valuable guest of ours who's spoken to us many times on different platforms that we've had, and that's Dr. Richard Freeland. Dr. Richard Freeland's the CEO of the Netcare Group. He is those of you who don't know him, and most do, but he's a medical doctor himself. He did veterinary science and then medicine, and then went into the management side of medicine. He runs and manages the Netcare Group, but more like important for this, besides his great overall management and even in this side epidemiological knowledge of what the corona situation, Dr. Freeland is someone who's really reached beyond himself on a community and broad across South Africa role to space to really make a difference in terms of making sure that we as a South African community take on the coronavirus time in a very responsible and efficient way. And the times before where he's shown us statistics of where we stand with corona has been really enlightening for us. He spoke to us at the peak of our wave. He spoke to us about 2 months ago, and I've asked him to just, you know, we are speaking tonight about the NHI and about what the plans are in terms of doctors and primary care doctors specifically. But just for 10 minutes or so, I'd asked Dr. Freeland 10, 15 minutes to speak to us about where we stand with corona, because it's enlightening to all of us to know what to expect coming up and where we're at. So without much more delay, and I see like we already have 350 people on, let me hand over to Dr. Freeland.
Yeah, thank you very, very much, Daniel. And to our colleagues out there, thank you for your enormous contribution over the last 8 months, and an incredible contribution, not only at the primary care, but also the tertiary care level. And wonderful cooperation between all of us, both in the public and private sector. And, you know, a shout out to Nicholas Crisp, who assisted very much in the negotiations between the public and private sector so that we could all work together in a national effort to curb what is an unprecedented pandemic. I will say this right at the outset, and I want to refer this to you. We've learned 3 things in this pandemic. Of course, we've learned many others. The first is that COVID is not a pandemic. Now, that might surprise you, but there was a wonderful article published in The Lancet, and I'd urge, if you don't have it, you can get it, it's free access, on 25th of September, which said that COVID is not a pandemic, it's a syndemic, based on the work by Merrill Singer, a medical anthropologist who coined this term in the 1990s. He works out of Connecticut, and was saying that our entire focus was purely on combating this virus and preventing its spread. But in reality, it was a synergy between other pandemics, and those pandemics being non-communicable diseases. And obviously, we realized in this pandemic that people hadn't optimized their underlying conditions, be they diabetes, hypertension, cardiovascular disease, obesity, and also poverty and socioeconomic deprivation. And so in many ways, what the Lancet is saying in their editorial is that we've got to tackle these other synergistic pandemics or epidemics if we're really going to be tackling COVID, because there will be other infections. I think the second one that we've all seen as colleagues in the medical profession and healthcare workers is that we cannot afford to lose our humanity, and COVID nearly threatened that. In many ways, it unmasks the fact that sometimes we're not great at communicating. So in our environment, as in the hospitals, usually patients' families were able to visit them and assess them and gain comfort. Here, they were completely isolated. In the beginning of the pandemic, people were dying alone, and we soon realized that we had to break some rules and allow people to put on PPE and come bid farewell to their loved ones, or alternatively have FaceTime. And I think it was a great clarion call to improve our communication, our empathy, and our compassion. And then I think the third lesson that's important for all of us, and you saw it yourselves in your own practices and working environments, we've got to take care of ourselves as healthcare workers. And it's something we've been pretty glib about in the past. We've paid lip service to occupational health and safety. And I think we've all realized, as South Africans across all sectors, that this is an absolutely critical element. And I'll just stop there for a second. I've put some slides together. They're the same slides I showed you as we were entering the early phases of the peak here, and then during the peak and after. And so I've kept the same format. And I obviously want to hear Dr. Crisp, so not take away too much time from Nicholas. So I'm really going to race through these slides and keep to the kind of format is to tell you where we are currently in the pandemic. I think the most important thing you can see from this graph here is that we are seeing a massive second surge or second wave around the world. And it's quite interesting that just recently, the number of active cases globally exceeded 500,000. And, we're talking about nearly 50 million people impacted. Now, take it back to that presentation I did on the Spanish flu, where most people died in the second wave. And you can see here where it was when we were going through our very first wave. Now, a lot of people are asking about a second wave in South Africa. I think that's somewhat premature in the sense we haven't really recovered from our first wave. If you use the World Health Organization definition of less than 5% of people testing positive on a daily basis, and less than 1 in 100,000 of our population being new active cases per day. I'll show you that later. But we're certainly seeing a surge in the Eastern Cape, and I'll point that out. Have a look at this on the right-hand side. Here on the left is just demonstrating what the rest of the world is going through. But here is something very interesting. This was the initial wave in Europe, and it was ghastly. We were unprepared. We've learned so much in this pandemic. But have a look at it. The second wave is 4 times the size in terms of numbers than it is in the first wave. I would argue that we are far better prepared as we were in South Africa. We've seen our lengths of stay come down from 17 days at the start of the pandemic down to just over 5 days for those who survive in hospital, and just over 5 days in total. And for those who survive, just under 4 days. And obviously oxygen and different modalities of oxygen, anticoagulants and steroids have been incredibly helpful. And in those with significant comorbidities and in elderly patients, in the early viremic phase, remdesivir has also been helpful. So you can see the second wave in Europe, and particularly in the colder climates, really some 4 times as high. This is what happened as of last night, the numbers that came out. You can see we're at 730,000, just under 20,000 people who've died officially. And I think we won't go into what that number could potentially be, but still about 7% of active cases. And as we've said on this webinar several times before, 1 day is not relevant. Let's look at it over a 7-day period. And this is what's happened over the last 7 days.
I put it in another fold.
Sorry, could I ask you to go on mute, whoever's that? Thank you. If you look at the trend over the last 7 days, you can see that active cases are declining somewhat, but we are seeing an increase here in the Eastern Cape, very significantly, a 29% increase, and over the 7 days moving average, a 44% increase here in the Western Cape, which is bucking the trend. We personally have seen a somewhat of a spike in KwaZulu-Natal and in Pietermaritzburg specifically, and certainly from a hospital perspective, we've admitted over 65 patients in the Port Elizabeth area just over the last 5 days. You can see the doubling time in South Africa has gone out to 108 days. Now, at the peak of our pandemic, we were talking about a doubling of every 14, 15 days in South Africa. This was the key measure that we measured, was the number of people turning out to be positive who were being tested on a daily basis. And so it's not just adequate to look at the number of tests or the number of people testing positive, it's the percentage of those that were tested. And at the peak, it was almost 1 in 4 to 1 in 3 South Africans. That's come down to about 7%. And if we look at what the World Health Organization says, that should be below 5 if we're talking about a real recovery. And you can see that the number of tests have held steady around the 20,000 number. These are the number of average daily new cases per week. And you can see them really remaining pretty static since the pandemic, but still haven't recovered to the early numbers that we were seeing in May. Average daily cases per province per week. Again, you can see these numbers have not yet come down in terms of the active cases. And really, is this the background COVID that we're going to continue to see, or will this reduce further, which we hope it certainly will? Now, the average daily cases per week per province, I think this really demonstrates what we're now seeing since the middle of October, the surge in cases in the Eastern Cape. The rest of the country really coming down and remaining pretty static in terms of that. This is a very important graph in terms of the active cases in South Africa, both from a lead and lag factor. And remember, I showed you the lag factor being this thick solid line. So really an average over the last period, whereas the active cases really are the lead indicator. And you can see that it's pretty static at the moment and pretty flat as we speak. And again, active cases across all of the provinces. You can see the Eastern Cape growing on here. Let's have a look more at the RT numbers. Again, these showing you very similar statistics in terms of what we're seeing in daily new cases per province. But let's have a look at the RT, which is a measure of the reproduction rate of the virus. I've shown you this before. It's the number of people that one person will infect. And we've used a model that comes out of KwaZulu-Natal, University of KZN. If the RT is below 1, the virus will die out over time. If it's around 1, it's pretty stable. And if it's above 1, it'll mean that there's an outbreak. There has not been an infectious disease globally where they've managed to achieve herd immunity naturally. And that's despite what we're hearing about high rates of potential herd immunity in our own communities. And clearly, we're going to be requiring a vaccine. We believe we're probably a full year away before we'll see that. We may well see the vaccination of people at risk initially. And this just demonstrates the RT of measles, of mumps, of SARS, and where we are. So let's have a look at it. It's my last slide, really, in terms of South Africa. You can see the RT as we've calculated it internally, and we do this on a daily and weekly basis, is below 1. However, in the Eastern Cape, it has now risen, given that surge, at 1.38. So I'm going to conclude there because I'm sure we all want to hear from Nicholas, but I don't think we've fully recovered in South Africa. Certainly, we're in a very different place than we were. We still need to use the non-pharmaceutical measures of prevention, and particularly ventilation, of masks, of social distancing, and of washing our hands. The jury is out as to whether we will see a second wave or not. And as I said right at the beginning, the textbook hasn't been written on COVID, so I don't think anyone really knows the answer. I know, Daniel, that was a whirlwind presentation, because that's not really the purpose of this evening, and I'll hand over to you for our next guest.
Thank you, Richard. That's exactly what we wanted. I think it's really important that we see the ongoing stats. And again, I thank you so much for the really scientific, quick presentations that you give us, that give us so much information. I'm a bit like disappointed by the fact that we all wanted to. I remember at our last meeting we were saying we were hoping that we're going to get 500 cases a day soon, and we're still sitting close to 2,000 on very many days. But I'm very encouraged by the fact that I'm not convinced that we're anywhere near a second wave at the moment, and hopefully we won't get to one. So, you know, as things stand, the stats are looking very good. Thank you for always sharing this information with us, which I think makes us encouraged as healthcare professionals. Thanks for your time. So without further delay, to get to the main speaker of the evening, I'd like to welcome Dr. Nicholas Crisp to tonight's talk. Dr. Crisp works at the moment for the Department of Health. He comes from a very rich and diverse background. To start at the end, he has the very exciting and daunting task of basically spearheading the NHI at the moment. He's a consultant to the Department of Health on the NHI, but works closely with the minister in terms of putting together the vision for the NHI. A bit of his background: he's a medical doctor and a public health specialist. He was the superintendent of the Department of Health and Welfare in the province of Limpopo, where he worked from 94 to 99. And he consulted not just in South Africa, but in South Africa, Nigeria, Ghana, Lesotho, Botswana, Namibia, Tanzania. So he's had a lot of international experience. And in 2009, he served as a special advisor to the Minister of Health then, who was Barbara Hogan. And he was actually very involved in the establishment of the NHLS. He has now worked very, very closely with our Minister of Health, with the spearheading and heading up of the NHI. And he obviously, as Dr. Friedland said, gave of his time at the beginning in the last months to deal with Corona. But as things have now become a little bit more manageable time-wise, he once again tells me about how, this is already his second webinar today, and he spent hours this afternoon on an NHI webinar doing this kind of thing repetitively and, really putting together the vision. So we're very grateful to have him with us. The Department of Health actually, approached and offered him to speak to us tonight. And what we're going to do is I've asked him, I had a little chat to him before the webinar, before the meeting, just to try he's had a lot of experience talking to clinicians. So to hone in on the issues that are on most of our minds. I've already received a few questions from people. And instead of him giving a presentation on the whole vision of the NHI and where it will be funded from, and which will already be very amorphous and difficult for us to deal with the issues that are on our minds, I've asked him to really speak about the things that make a difference to us as doctors. And then he's felt certainly that would be constructive, and there'll be time then to really hopefully ask him more. So we might not agree with all the concepts from the beginning, but we need to hear them to understand them and to learn about them, so we're able to start formulating ideas and feelings and support of some of the wonderful things that the NHI does stand for. So without any delay, welcome to Dr. Crisp.
Okay, good evening, everybody, and thank you very much, Daniel. Thank you, Richard, for that presentation. I will resist the temptation of getting stuck in the COVID debate, but would like to thank you and all the colleagues who were involved with working around trying to get public-private cooperation and working together for COVID. It was a difficult time, but it was fascinating and for me personally an enriching period. So I'm looking forward to building on that for NHI. Okay, so as Daniel said, we'll try and focus on practical issues rather than on the high descriptions of what is in the bill. But we need a little bit of ground description of what the NHI is about and why we are moving towards a national health insurance. The first thing
sorry to interrupt you,
yes.
Dr. Crisp. Just one thing I omitted to say is that when I did ask Dr. Friedland to come on very recently. He does have another engagement tonight as well. So I just wanted to thank him and tell him that if I know that he has to go, I don't know what time exactly, and we'll all forgive him and not feel as though he's leaving us here. He actually made the time to fit in this meeting as well. So thank you very much, and please carry on as you were. Thanks, Dr. Chris.
Okay, sure. Thanks very much. Okay, so the first thing to say is that we are not the only country who is busy with major health sector reform. There are more than 40 countries in the world who are grappling with major reforms, and there are literally 100 countries around the world who are unhappy with their health services and are trying to implement some form of changes. Ours is a pretty radical approach and a pretty radical reform that we're looking at, because we have an extremely inequitable health service. Relatively speaking to other countries in the world, we spend a lot of money on healthcare as a country, around about 8.5% of our GDP, and we are the 30th biggest economy in the world. And to be spending 8.5% of that GDP on healthcare should be giving us far better outcomes than we are getting at the moment. A large part of the reason why we are not getting good health outcomes is because of the inequity in our dual system that we are running. So we spend more or less half of that spending in the public sector from general taxes that gets allocated primarily to provincial governments. And then the provincial governments, from their provincial equitable shares, allocate money for health and education and so forth. And the bits and pieces that are allocated to health get added together, and that forms what we loosely call the national health budget. There are other components of the budget that come from conditional grants, which I don't want to get into too much now, but they are a way of steering specific policies in the public sector. So that loosely accounts for about 4.5% of GDP and amounts to around about 260 billion rand a year. The other half of the 8.5% of our GDP that we spend on healthcare is spent in the private sector. The bulk of it is spent through pre-financing, through voluntary contributions, as you know, to medical schemes. Some of it is to health insurance products, which are bordering on illegal, many of them, but some of them have got through on some other pieces of legislation and don't fall under the Medical Schemes Act, but relatively speaking, they're small. And then there's quite a sizable portion of people and money that is spent through out-of-pocket spending, and that's the people in the margins who've got a little bit of money, but are not necessarily able to afford to spend on a proper medical scheme, might go for a hospital plan or none at all and try and pay their way with cash. So that is roughly another 4.3% of GDP spent there. The problem is that this is such a fragmented, difficult system to manage with so many different players and rules that our healthcare is not interoperable. Our records are not interoperable. We end up duplicating laboratory tests, x-rays, consultations, confusing patients with a whole lot of different financing systems that they don't understand, even their brokers don't seem to understand, and it adds huge amounts of costs that don't give us improved healthcare. We also, in the public sector, have serious problems with corruption, and in fact, in the private and public sectors, we have huge problems with medical legal insurance, either claims or spending on insuring ourselves against those eventualities. So there's a whole lot of reasons why our system is costing us way more than it should be costing us. And we, when we are patients, don't benefit. And we as practitioners are not necessarily the ones benefiting from the system either. It's other peripherals in the system. So that's the background to the fact that we are in trouble. The public sector will implode if we leave it like it is. The private sector will become so expensive that it will also implode and we will lose members. And now during COVID, as people have lost jobs, that's going to happen anyway. And we need to relook at how do we use all these resources from the public and the private sector that more efficiently. So the starting point is that the National Health Insurance is a financing system. that it seems not to get across in the public discourse. It's a financing system. And what it says is that we should pool our resources into a single pool. That's the principle, and many countries will go for that in principle. In practice, there are provisions in the bill that it's not a single pool. There will still be medical schemes to cover benefits that are not covered with the money that, the benefits are not going to be covered by the NHI, and we can talk a little bit about what those benefits might be and how they get paid for. And those are called the complementary services, and those of you who follow the discussion and debates around Parliament will know that that is going to be one of the issues to thrash out in the parliamentary process. So we are going for a single pool with a single payer model where the National Health Insurance Fund is set up as the single payer in a purchaser-provider split. So where the purchaser, being the NHI fund, not the government and not the provincial health departments and not medical schemes, are the primary payer using our tax money, and I'll come back to that in a minute. And we're not going to pussyfoot around the fact that it's our tax money. That's the reality of it. And the payer will then buy services on behalf of us as the residents in the country, primarily citizens, but also other residents in the country, from public and private providers. And the key and the issue for today, for this discussion, is that we need every provider we can possibly get. We have scarce resources, including doctors, physios, OTs, and every other kind of professional. We are all scarce, and we need to make sure that every one of us is available to provide as much care as we can. So we're not in the business of setting up an NHI to exclude the private sector or force the nationalization of the private delivery sector at all. It's the financing system that will primarily change. But it will change the service delivery model, because the objective of having this kind of centralized pool, and we'll talk about how we deal with corruption and information and so on in a moment, the objective of having a centralized pool in this manner is to achieve equity through strategic purchasing. So what you're trying to do with a model like this, and as I said, we're not the only country, is to purchase on a needs basis, not on a supplier-driven demand basis, and not on a lowest common denominator basis, which is how provinces eventually wind down over time, and we end up with some of the problems that you've seen during COVID in the media. So we want to get to a situation where the fund does what's called strategic purchasing by using large amounts of data that we collect from patient records. We build up over time a lot of information about who has what epidemiological, which communities have what epidemiological needs, and we target the purchasing of services to those communities, not to the clinicians, that's the byproduct, but to the communities. So over time, we'll be able to detect that, for argument's sake, some community around Lusiki over a 12-month period, we never see anybody with, for argument's sake, prostate cancer. We know that's not possible, so we now need to go and establish why is that happening. Is it because we don't have sufficient providers in the area who are capable of diagnosing? Is it because there's a failure in our referral systems, or the patients are so advanced and they die from other things, or that they're just not feeling they have access to the health services? So that's just one example. Okay, so the essence of what I'm saying is that the model, the NHI is a financing system with a single pool, purchaser-provider split that will purchase from public and private providers. Now, the trick in these models, and as I say, we are one of many countries doing this, is to make sure that you get, that you design the system to improve quality, and you do that through proper certification and accreditation programs. So a part of the NHI's intention is that, first of all, the Office of Health Standards Compliance will start with certification of compliance with basic standards, and over time, those standards can get more and more sophisticated. And then there are, in Section 39 of the bill, 6 criteria for a practitioner, whether it's a public or a private practitioner or establishment, to be accredited to provide services to the public sector. And they include things like interoperable systems, agreeing to use the formulary when prescribing for patients, and you can go and read them yourself. And they are pretty straightforward, standard things that you would be familiar with from dealing with medical aids anyway. But they will be standardized for the country, not for selected sub-pools. And that's the design of our system. Now, there are obviously lots of technical complaints. There are issues around how the governance structures are described in the bill and so on. For tonight's purposes, I don't want to go there. I'm happy to come another time and talk to you about the challenges around the wording of various parts of the bill and so forth. So I would like to focus for 5 minutes on providers. And specifically because I was invited by GPs, I'd like to focus tonight on the GP and not really spend time on the hospitals and the specialists. Obviously, that's important, and the linkage will be through referral. But let's look at what the bill says the NHI will establish by way of reforms to the provider system that will affect the GPs. So what it says in the bill is that the primary healthcare system of the country will be organized into districts. There will be a district health management office, not vastly different from the current district health administrations in the public sector, except that these district health management offices will now be for the whole health sector, not for the public service to look after their own district services. And the district health management officers are responsible for developing the service framework and network within their district, and there are 52 districts in South Africa, that will identify where we need hospitals, where we need outreach services, etc. And part of their responsibility is to set up contracting units for primary healthcare. Now, you will only see one line about contracted units for primary healthcare in the bill, but if you scroll down to the schedule at the end of the bill and you get to the portion on the amendments to the National Health Act, you will find section 31 capital A and section 31 capital B. That section 31 capital B describes in a little bit more detail the organization of the primary healthcare structures that the NHI will purchase services from. And what it says at a high level is that the NHI must, not may and will think about it, must purchase health services from a contracting unit for primary healthcare using a capitation fee payment to that contracting unit for primary healthcare. So now the question is, what is a contracting unit for primary healthcare that's going to get this pay? And how do we determine the capitation? So these capitation fees, if you look at WHO literature and what's happened in other countries, are risk-adjusted capitation fees. And in our case, I would very much like to see, and we will see how far we can do this in the modeling, we would have a value add component to the risk-adjusted capitation fee. So a risk-adjusted capitation fee says, if we have 100,000 people in the catchment area, then we would allocate a certain rand value to each of those 100,000 people, but we would weight it for the risk and the anticipated spend on each of those 100,000 people. And at its simplest model, we know that we spend more on children under 5, pregnant women of childbearing age, and the elderly over the age of 60. But over time, you want to be way more sophisticated than that. You want to collect patient data, and you want to understand case mix with severity. You want to know how trends are moving, and you want to set outcome targets so that, for instance, complications that are referred to hospital for patients with diabetes or hypertension are reduced over time. And you want to pay more to people to give them incentives to get that kind of service in the primary healthcare space. So the intention of a contracting unit for primary healthcare is it's all primary healthcare providers from what we call the WABOTs in the public sector, the ward-based outreach teams, which are largely community health workers and other outreach staff who do household visits and follow up on chronic patients, identify risk patients, look at mental health in the communities and so forth. And they refer patients to clinics and in the future to general practices. And then the primary healthcare clinical providers refer patients that they can't manage or need further investigations or treatment to a district hospital. So we can anticipate, knowing the present structure of the health service, that we will have somewhere between 220 and 260 of these contracting units for primary healthcare, with a catchment population around a district hospital. And then over time, the public and private providers will become part of that network. So that is very different from what has happened up till now. In the preceding years, when there have been these various pilots going on in primary healthcare, what we saw was pretty much contracting of some general practitioners as employees or part-time employees of provincial administrations to go and work in state clinics or hospital outpatient departments. That's not a constructive long-term solution. That's not what we're looking at going forward. What we're looking at is more, for those of you who have colleagues and friends in New Zealand or have already investigated moving there, the kind of GP practices they have there are networks of GP practitioners, doctors, with physios, OTs, pharmacists, other practitioners, and they work either in a multidisciplinary team in a single location or through a network where they offer 24-hour referral services to the communities around them. And they become part of a wider network of primary healthcare providers linking with the public services in that space. So we are working together with the various GP formations and organizational groups to put a model together and to look at the costing of how this might be structured and what the rules would be. And the bill says that we would then contract the CUP, and the CUP will then be responsible for the distribution of the allocations to these contracting units, the capitation allocations to the providers based on the services and the outcomes they provide. So it's complicated. It will happen slowly. It will be piloted to get. I've got a thunderstorm here that went off like a big firecracker. So these reforms will be rolled out through proof of concept, and they don't happen in a vacuum. There's a fairly sophisticated set of or network of digital requirements for people to be able to network into these contracting units and participate. And the amounts of money that are available and have to be moved out of the provincial equitable shares take time. They have to happen in line with financial years and so forth. So I think what I really wanted to do this evening is just give you a smattering of those are the high level frameworks of what the bill says and what the intention is that's described in the white paper. And what we are doing at the moment is building the systems that make these things possible. And during the course of next year, we will start to put sentinel sites in place, working with some of the general practitioners to see, does this work? How does it work differently in a rural area from an urban area, et cetera, et cetera. So I think I must stop there and rather take specific questions that people have. And if it's necessary to come back another time, I'm very happy to do that. So thanks, Daniel. Let me stop at that point.
Thanks, Dr. Chris. So that gives us a good idea about what the general plan is, especially related to doctors on the ground. I think the best way maybe to tackle this is I've had quite a few questions, not realms of them, but I've had quite a few questions come to me. And I feel like the questions are important to tackle specifically if they are relating to, from a doctor's perspective, real simplicity in terms of how will this affect doctors as they are at the moment versus how it will be then. So maybe I should start off by, posing a few of those to you, and we can just go backwards and forwards and try and be brief. And then afterwards, we'll see what's coming through on the chat. So, just off the top of my head, some of the questions have been like this. If someone's a GP at the moment in their current, practice, will they be able to keep their existing patients? I understand that there'll be there was an acronym that you guys put together. I don't know where, somewhere in my notes here for, you'll tell me what they call that, who run the different division of patients. And patients will obviously apply to be part of the NHI, and then they will be assigned to doctors. Will doctors be able to choose their own, patients be able to choose their own doctors? Will doctors be able to retain their current patients? And let's put into that question as well, patients on medical aid schemes at the moment, is the plan that they will, leave their medical aid schemes, or will they be allowed to stay on their medical aid schemes, and which will cover things presumably not covered by the NHI?
Okay, so thanks. There's a lot of very useful questions in there, and let me try and take them one at a time. So first of all, patients have choice about where they register and where they get their primary health care. So if you are routinely getting your primary health care at a general practitioner close to your home, that's where you would go to register and to get your primary health care. Of course, that general practitioner then needs to get accredited with the National Health Insurance, and that's going to take time before we get to that point. If your normal way of getting healthcare and you live in Malamalele somewhere and there isn't a GP near where you stay, you would routinely get your healthcare at the clinic in your village, then that's where you're going to go, and that's where you're going to routinely get your healthcare. So around the country, the answer to the first question is patients will register at a primary healthcare facility, and the bill says they will start there when they have healthcare needs, except if there's an emergency, in which case they can go to a hospital and they will be seen in that emergency. It's then up to that practitioner to refer them. So what it's doing is it's saying your primary point when you have a sick child is not the pediatrician anymore. It's the GP. And if there isn't a GP and your primary healthcare provider is a clinic sister in the public sector, then that's where you will start. And then from there, you will be referred by that practitioner. So do you get to keep your patients or not keep your patients? Yes, you do. And over time, that book of people who are registered at that primary healthcare becomes let's call it the book that we will see in the National Health Insurance Fund. Of course, what we are interested in the National Health Insurance Fund is outcomes. And some practices don't necessarily get very good outcomes, and others get very good outcomes, and we want to reward the outcomes. So having to define them and have a few clear outcomes and to not try and take too many at a time that's too complicated to measure will be the trick. And that will be a collaborative process, which will eventually get gazetted, which means there's a participatory process attached to that. So the next question you asked me is what happens to medical aid patients? So let's take a person on a hospital plan. They're not a medical aid patient because they've got to pay either out of their savings or cash, but they will still go to their general practitioner if that is their routine process, or they will go into the public sector primary healthcare system to get their curative care or to have their consultations. At the moment, if they're on a medical aid, the practitioner or the patient will claim from the medical aid for that consultation, whether it's a PMB or whether it's covered by whatever your package covers, that is how it will be paid for. Once the NHI is at that point of evolution, which is not going to happen in the first 6 months or the first year, that's for sure. Once we're at that point where the benefits are defined, they're in the public space, the budgets have been moved out of the current budget arrangements in the public sector into the NHI. The NHI has a board with a fund, with bank accounts and all of the other things that have to be set up. And these things, believe me, I've done this before with the NHLS and with SAPRA, take time. When we get to that point, the bill says there will be an announcement of a date, at which date the medical schemes will not be allowed to cover the benefits that are paid for by the NHI. So we don't want a dual system. But the medical schemes will be allowed to cover whatever's not covered. So usually, if we look at how other countries have done it, it's done in a stepwise fashion. So you may pick a comprehensive primary healthcare package, which mimics the current primary healthcare services provided in the public service. And we are going to try and harmonize the PMB process with what happens in the public sector. So that we, as quickly as possible, can have one basic package across the public and the private sector. Then that will become what the NHI will pay for. And then you and I and anybody else who's on a medical scheme will not need and not be allowed to have a medical aid that covers those, because we're going to pay for it through the NHI. It will take time before the next phase of curative care in hospitals is rolled out. And the reason it takes time is because you need to collect data. Now, in the private sector, the data is pretty good, but in the public sector, it's not across the board good. It's fairly good in some hospitals, but it's fairly bad in other hospitals. And it'll take us time to get a consistent system. And that's one thing COVID has done for us, has made very good, which it's really improved our data management between the public and the private sector, and the way in which we manage that data and analyze that data. So I hope I've answered your questions, that this is not an event. This is a process. It's not even a marathon. It's a long journey. The UK started after the war, when Bevan stood up as a minister and said the NHI starts on Friday. And then they panned to the shots in the streets, and half the hospitals were still bombed to pieces and whatever, and they started. And today they're still struggling to improve and to do all kinds of things, and they've experimented along the way. And we can tell you similar stories about every other country. Ours will also be start slowly. The economy is not very, the economy is abysmal, so you're only going to be able to do certain things and so forth. And we will consult as much as possible and understand the different models as we go. And we want to have these forums that we've got going during the NHI, during the COVID time for NHI, so we can really hear how things work on the ground. I hope I've answered your question.
Thanks, Dr. Chris. Like we spoke about before the meeting, I think it's good that we group the questions just for time, and for everybody who's on this meeting. I'll do this for the next 10 minutes or so, and then I'll open it to the questions that are coming through live. So just to hone in a little further on the things that you just discussed, I'd like to ask you, in a free market that's maybe a capitalist in society, at the moment, one could argue that with the current healthcare infrastructure in public, patients have had the opportunity conceptually to go to hospitals and get free healthcare if they're South African citizens, and they've opted out of that over the years because, for whatever the reasons are, the current infrastructure hasn't been able to support them. Going forward, is there a possibility here that patients will do the same thing? So in other words, if we're in a situation where the infrastructure is strained and there isn't enough, because as you said, it's a long evolution for this whole thing to come together, do you envisage that patients will still want to pay a private medical health scheme like a medical aid for another stream of medicine? And then isn't it anti-competitive not allowing medical aids to cover things that the NHI will be covering, because that's almost like curtailing a free market the way we see it at the moment? So let's deal with that one, and then I'll come to something else.
So let's deal with that by saying our problem in South Africa is inequity. It's not free market. Our problem is inequity. We are going to get the youth are unhappy, communities are unhappy, people are fed up with being downtrodden, not having access to jobs and whatever. And those of us who live in the world of medical schemes and access to private healthcare and private schools and whatever don't really understand until we get out into these communities just how rough it is out there. 10 toilets for 50,000 people in the corner of Khayelitsha somewhere just does not cut it anymore. I worked with those people with the Western Cape government now during COVID, and they said, we're not going into isolation and quarantine. Because if we leave to your fancy 4-star hotel, when we come back, no TV, no house, somebody else will have moved in. There's no ways I can leave this place. I will take my chances walking down the road to the spaza shop and to the toilet, and it's just toughies for everybody else. That's how it's going to be. That's the reality for the vast majority of South Africans. So you and I, and those of us on this forum who are predominantly professionals, mostly health professionals, have just got to understand that that's the community that we are trying to serve. We are trying to get access to those services. And if we lock resources where 15 to 17% of the population is using 70% of the specialist care, we're not doing the specialists any favors, because they're no longer seeing the really complicated clinical care that we would really like them to see. The GP is no longer seeing the patients that he would like to see or she would like to see, and so forth. So for the NHI, we're not talking free market anything. We're talking about equity. We're talking about spreading the resources. But we are talking about choice. And we are talking about proper quality healthcare that you and I, who went to medical school and worked really hard to get our qualifications, are proud that we can provide a quality health service. Now, sometimes for some people in certain facilities in the public sector, that is really difficult. The facilities are old, they run down, their budgets are too small, their staffing is too small, they've imploded on themselves. And we saw that in the pictures in the media during COVID, and you and I can give examples of some of those things. But those who work in the public sector will tell you there are also centers of excellence, where if you were to be really sick, you would choose to go to some of these public sector hospitals. And I can name some of them around the various provinces, but maybe it's unfair to do that. Really, really good facilities, excellent clinicians. We all train in the same space. So let me give you an example to try and answer this question. The community of Diepsloot in Gauteng and Cosmo City in Gauteng, they're on the fringes of Region A of Johannesburg Metro, and Skya Sands and so on. They crammed into very unhappy working situations. And when they need healthcare, there are a few clinics, some private and some public, and some NGO services. But when they need hospitalization, Diepsloot's referral hospital is Tembisa. It's on the other side of the N1, way over, far from where they live. And for the community of Cosmo City, it's Ontdekkers, Discoverer Hospital, or over the hill to Krugersdorp to Yusuf Dadoo. But there are a whole bunch of private hospitals much closer. And I won't risk picking on Richard Friedland or on his colleagues in life or whatever, but there are a number of hospitals. So what the NHI says is, we would like you, Richard, and your colleagues in the other facilities to be accredited so that some patients can be referred by those primary healthcare practitioners and GPs and facilities in Cosmo City and Diepsloot, not to Tembisa and to Charlotte Macheke and to Ontdekkers, but to your private hospitals, which are much closer. And we're going to pay you. We're not asking for you to do this free. We want to buy it from the fund. So that's the public-private. It's not a deal or a public-private partnership. This is the framework of the NHI. And that's how we start to get access for poor people to the National Health Insurance. It won't happen overnight, and we won't be able to accredit every single facility all in one go. But we do need to start with a few to show that it works, find out how it works, work out what the systems must do, and start giving services to people who are desperate. Thanks.
Okay. Thank you. Thank you, Dr. Chris. Thanks, Nicholas. Just to be clear here, but to set the right tone here, I'm specifically asking the questions here that are the questions at, at the heart of this debate.
Sure.
I think that the principles of the NHI we support, there's no we, you're all individuals here, but many doctors support. And I think that it's really, but part of moving forward with this amazing endeavor is to try and address the apprehension and the concerns of individuals who work in the private healthcare sector and in the public healthcare sector. We desperately need as a country to put away the inequality and the unfair distribution of healthcare resources. And we have to look at how this is now going to impact both the people who use it and the people who provide it. And that's where I'm coming from in these questions. The next question is perhaps more of a governance and financial question. There've been quite a few questions coming through as to saying, like, in the public sector at the moment, we've seen, even in the time of COVID, issues with corruption, issues with governance, and we've seen as well how difficult it is taking scarce resources and sharing them amongst an already strained system. And now I do understand, and I've read from some of the literature about how there'll be obviously much more income into this from different taxes. But the reality is that what controls are going to be implemented to make sure that we don't run into a system where there is abuse and where there is corruption, and where, you know, we're taking perhaps some sectors of healthcare that are working and just, you know, sludging them. So I know obviously this is being addressed. Can you just help the reassurance about this?
Yeah, I mean, it's the one thing that keeps me busy every day, is how do we deal with risk identification? And I'm talking now more from the NHI fund perspective. I'm not talking about patient risk and adverse events. I'm more talking about the risks of money being stolen, so fraud and corruption and so forth. So we have a risk framework which is being developed. So I co-chair a committee with Advocate Andy Motivi, who's the head of the SIU, where we've been putting the risk framework together. And what that involves is understanding the processes of how the NHI will be set up. And this is not dissimilar from what any medical scheme or medical scheme administrator would be doing in their business. You identify the risks in the processes. Where might a patient abuse the system? Where might a provider abuse the system? Where might a supplier abuse the system? How could the staff abuse the system? Who might want to hack into the system and get hold of patient records or do whatever, and so forth. So you identify in all the processes, as far as possible, where the risks are. And then the systems are built to triangulate, for instance, ID verification. We have a serious problem in this country. We can't use ID numbers for our single patient registration because there's so much ID fraud in the country. So the answer is to work with the Department of Home Affairs to find out why is it like that and how are we going to work past it, and how are we going to work with it in the health sector using biometric identification, so that if I say I'm Nicholas Crisp and that when I come for healthcare, you know it's me. And when I pitch up at the next GP down the road and I start trying to collect the same script 4 times in the same week, the system flags it and said, this patient is doing something which is abnormal and shouldn't occur. And we are able to either stop it right there at the point of care or whatever. So there are lots of points within the system where our IT systems that we have built and are busy improving on will identify and flag risk and either prevent the transaction completely or flag it and say this needs to be investigated because there could be some abuse here. So corruption and fraud are a massive issue for us. One of the ways to deal with this is transparency. Put it out in the public domain. Make it known what tender, you know, who's getting what. Make it known who's providing what services, and show in public dashboards what a particular provider is doing compared with a peer provider and so forth. And there are lots of examples of how you do this, and they also have to be quite judicious because you don't want to break the system and intimidate people too badly that they don't want to participate anymore. But that is another way to do it. Then, of course, there's the physical security and the cyber security issues. And fortunately, today, there are all kinds of weird and wonderful, incredible ways of protecting our data. And with our PA Act, that's very important to us. But we do need interoperability, so that if a patient moves from his GP to a hospital and then is referred back and goes to a home, and a nurse goes there to check on the patient at home, post surgery or whatever, that the patient record can be tracked. And somebody like me, who's a migrant worker who lives in one province and works in another province, if I get sick in one or the other places, my records are available. And that makes it vulnerable, and you need to lock and protect that interoperability and make sure that you don't compromise individual patient records and so forth. We also want to pay the providers. And we want a system where you don't wait. You don't have to send an invoice and you wait 30 days and so on. That is not a viable system. We want a system where, as the patient is seen and the code is registered that the service has been provided and the benefit is legit and it's been triangulated and so forth, there's a price attached already, which is in the public domain. Everybody knows what it is. They get negotiated once a year. We all get paid exactly the same for the same procedure or DRG, or however it eventually is described. And the NHI is collecting those for your hospital or your practice as you go. And at the end of the period, whether your contract is weekly or monthly or 2 weekly or whatever, the invoice is generated by the provider and it matches immediately, and the payment is made automatically. We don't want money sitting around waiting in bank accounts to be defrauded. We want the turnover of that money to be verified as far as possible automatically. I don't want to make it sound simple, because it's not, but we have learned a lot from our colleagues in the banking sector and other sectors that these things are definitely possible. So you need to really be assured that I pay a lot of tax myself, and personally affronted by what happened during the COVID time. We've tried to understand why these things happen, and we're now designing systems to, as far as possible, design it out and to protect all of us, that we get best value for money. Thanks.
Okay, so while we're on the money, and I'll do this one more of these general questions, and then I'm going to go to the chat, is there've been a few questions about the model of remunerating clinicians, specifically GPs. We've seen that in capitation models, often motivation gets lost amongst doctors. Fee for service, the one big advantage of it is that if you work harder and you work smarter and you work more efficiently, you earn better. This is a concern. I had an email from one of the specialists saying, if you're going to be limited with a set capitation, what will be your incentive to work more and do more? That was the one thing. And the other thing, while we're on fees, is if there are different districts and there's a different distribution according to the population, will we be in a situation where denser areas have got more thinly spread funds, because just that's the way things are? And will we have to, will it be a real push to be able to get enough of a pathway of care as a result, specifically in urban areas where the system is taxed a lot?
Yeah, okay, so thanks. That's also very important questions. So let's start with the second one. The answer to your question is yes. Denser areas, if the allocation in the primary healthcare space is done on capitation, there's more money. But if the providers are extremely dense in that area, then obviously the amount that is available for each practice is reduced. And if that community is a lower risk community than another one with the weighting of the epidemiological need, then yes, those practices, there's less money in the pool to pay for that care in those practices. So that is how it works. It doesn't happen overnight, as I said, it happens over time. And countries who have done this find that young practitioners who are starting out, instead of taking over and trying to compete with a colleague where in a densely serviced area, start to move into the more peripheral parts of the system where it's now more viable because there's more money in the system to pay for them. And they are able to set up a thriving practice there where they may have found it difficult to compete elsewhere. That happens over almost a whole generation. It doesn't happen in a short space of time. So again, one has to be careful how you do it. And that links to the first part of your question. Pure capitation, where you just allocated money and there's no incentives whatsoever, you just get paid and you submit your returns, is not a constructive way of managing capitation. We know that, and we've looked at capitation systems in a number of different countries. In South Africa, there are a number of very interesting projects going on, mostly in the private sector, but some are linked with the public sector. And we know, because we work very closely with GEMS, because it's in the public sector space, that they have been experimenting with a number of these value-added contract services for in the GP space. And the results are extremely encouraging. Costs come down, practitioners get paid more, and you get better outcomes. There's less referral for hospital care because the practitioners are motivated to spend that little bit more time with the patient to make sure that they don't get referred. And over a period of time, the whole community starts getting more healthy. And that's the outcomes I was talking about. Now, building an outcomes-based model requires quite a lot of data. And so it's not the first phase of the implementation. And until there are sufficient providers in the network that are part of the accreditation, and until there's sufficient data from those providers and of that community, one has to keep it very simple. But that's the direction that we are moving in. And those practitioners who work in these value-add capitation models at the moment in this country will tell you that they actually like it. I spoke to colleagues of mine who I qualified with at UCT way back in the dark days, the ancient days, who are now in New Zealand, and they say they love it like that. It's the answer. So it does need to be nurtured. It's not something that'll just happen. Thanks.
Okay, so I'm going to leave the camera on you, Dr. Crispin. I'm going to go to a question that was asked at 8:41 in the chat. It says, during the COVID pandemic, the government allowed no negotiations on fees by the medical practitioners. It simply tried to impose unrealistically low fees for medical services, a take it or leave it basis. I assume that was for sessional work. This is Dr. Andre Roux is asking. How will the NHI be different? And just to broaden that question, is that who will determine what the capitations are? Will there be clinicians consulted? I mean, I think that part of the ambivalence is that, at the moment, doctors know doctors in private earn whatever it is, 400 Rand for average medical aid patients or whatever is per session. What happens if the NHI comes out and says from now onwards, your equivalent will be 200 Rand a consult? How do we feel more encouraged that the fees will be competitive, will be market related to what we're used to?
Okay, so let's start with that one, and then I'll go back to Andre Roux's question about what happened during COVID. So practitioners don't all earn the same amount, and practitioners charge very different rates all over the country. I live in a very small rural village, and the nearest town to where I live is 67 kilometers. And there's a really nice general practice in that community with a group of nice GPs. They get visiting specialists, they have relationships with physios, etc. I like it. It's very nice. And it's much cheaper than if I get sick here in Gauteng and I have to go to the GP down the road. But it's actually a nicer practice. It's actually a more comfortable environment. It's a much more friendly space to be cared for me, but it's cheaper. That's what the market has done, and that is how it has panned out. So for those practitioners in a unit cost cheaper, if you like, used to less environment, they may find that the model under NHI favors them. I'm not saying it will, I'm just saying they may find that. And you may find somebody who's got really expensive rooms, 16 other practitioners on the same floor of the building that they're competing with, and it's it's a very difficult space to work in and so on. You may find that they are charging a lot more because it's costing them a lot more, and it's going to be more difficult for them to participate at the same kinds of levels in the NHI. We don't know until we do the figures and we put them on the table and have a look. Time will tell. So the question is, who's going to set these rates? The bill says that the NHI fund will, well, it doesn't actually say, but what happens is the fund administration does the legwork. Then they have to give those to advisory committees, which are appointed by the minister, and this has been one of the governance objections. And then that advisory committee checks the work and feels that it's not fair, or it is fair, or it's not been properly consulted, or it has and it's appropriate or not appropriate, and makes a recommendation to the minister, who signs the gazette. That's the way the bill is designed. It's not dissimilar to how things work at the moment. That's the point at which the question is, who sets those tariffs? So there's a unit designed into the NHI office where that all the economics and actuarial work and the numbers are done, but it's done together with health practitioners, and then there will be these advisory committees. Once again, it will not happen in one easy shot. Let me answer quickly that question from Andre about what happened during COVID. During COVID, the clinicians came to us, and the us was me in this case, because the minister asked me to do the negotiations, and said, we want to give services at cost recovery. We were thrilled. The hospitals came, including Dr. Friedland and his group, and the other groups came to us and said, we would like to participate. We want to offer cost recovery. And I mean, it was fantastic. But in the process of trying to set those prices without time and without proper negotiation, we weren't allowed to negotiate at the time. We had to talk to people separately and so on. The system that was used was to compare with what a public sector doctor earns, rather than add up codes in a medical scheme, which are very difficult to take cost, to compare cost with price. The discussion was around what would a public practitioner be paid on average to do the same amount of work. So it wasn't to take it or leave it. It was a discussion. Some of the rates were too high and some of them were too low, and some of them were not appropriately designed. But the goodwill was fantastic. It was not that anybody forced anything down anybody's throat. Thanks.
Okay, great. So questions at 8:41 from Michelle and 8:45 from Belinda. Where I think this is really around the structure, just for GP or doctor at the moment who's practicing, who would like to position themselves well for the NHI. Is there an advantage for being in a group practice as opposed to being on your own? Is there a way to try and get yourself, a credit, that when the accreditation happens, how are these district offices going to be set up? So just very briefly, we've got a lot of questions to get through, and I want to do it in about 10 to 15 minutes. Is, anything about structure at the moment for doctors?
Yeah, so the short answer is group practices will definitely be easier to work with than solo practices going forward. And at the moment, the constraints that we have around multidisciplinary teams, we want to undo that and make it much easier to work in multidisciplinary teams. So we can go into the reasons why on another time, but solo practices, it's difficult. Very difficult to provide a 24-hour service or a comprehensive service if you're not in at least a network, if not in a group practice. As far as district offices are concerned, there's varying experience around the country with district offices. Some of them really are not useful and others are very good. But in general, their problem is they are designed in silos. And this is something that has evolved over the years in the public sector, where the silos are HIV and TB and this and that. And really, that is not the way we want to provide healthcare going forward. We need to integrate those care programs, and we need to focus on the patient, not on the disease. So that is going to take quite a lot of redesign. But the District Health Management Office is designed to be a different kind of animal from the present district offices, which is a provider supervisor, whereas the District Health Management Office is not a provider supervisor. It's more the steward and the oversight body. Maybe some technical words and the understanding needs to unpack those words, but they will be a different kind of animal.
Okay, thanks. At 8:51, so, Dr. Ramlachan asked, he said, why has a primary package not been defined yet? And then there was another question that came straight after that that said, a patient at the moment who goes to a clinic, this was from Dr. Levine, who now wants to go to a GP, will they be able to, change from a clinic to a GP? I think those questions are a little related. In other words, the one relates a little bit to like what service you can get, another one is where you can get it. But will this all become one system? And like surely that will take quite a while to achieve.
So you're right, it will take a while to achieve, but yes, patients can move from one primary point of care to another primary point of care. And obviously for us who are trying to plan capitation, we just need to know where the person lives and where how it's affecting the capitation, and whether the clinical coding that we are picking up is giving us information about the needs of that community and how much we are spending on the care of the patients in that community. So the answer to that is yes, there is mobility, and many of us and many South Africans are migrants and work and live in different places. And so you need to have more than one point of care, and portability is really important. The question of the primary healthcare package, in fact, in the public sector, there is a primary healthcare package. It's started off by being built on clinical guidelines rather than as a package. And there's a project at the moment to take it and make it into a discernible, codable package so that it's clear. But what we also want to do, and I alluded to this a moment ago, is that we are now starting to work far more closely with the Council for Medical Schemes. And those of you who are familiar with the health market inquiry will know that there was a recommendation that we relook at a basic standard package across the board. Well, it would be advisable for us in the public sector and the private sector to try and harmonize those packages so that we're moving towards a situation where all the public knows what to expect in the primary healthcare environment. That's ongoing work. It's doing pretty well. And I think in the early part of next year, we should have a sense of what that is and what the costs are involved in that. But of course, we can't publish it as NHI benefits because there's no NHI yet until the bill is through Parliament, and that's going to take time still. Thanks.
Okay, Dr. Crisp, I'm trying to group a few of the questions here. There have been a few questions about timeline. I mean, at 8:53, Dr. Moloko asked, should we not be looking at how far we've come? We started talking about this in 2012, and there've been some pilots, according to this question, there've been some pilot projects so far. I'd like to couple this with the questions that have said, like, well, what do you see the timeline being here? In other words, we're talking about this, and I can see the great vision of us being able to onboard many more South Africans. But and I also see that you're saying that realistically, so this is a long process, and it's obviously going to have its mistakes on the way and its discovery. But the question is, how long do you think it will take until GPs are able to accept patients, all South Africans, and funded by the NHI into their practice of some one form or another for consults?
Yeah, so obviously we do set ourselves targets, but don't have a crystal ball. So to be able to say this is definitely going to be on that date is not wise for me. There are dates that are published in the bill, whether they're achievable and whether it's clearly defined what will happen by those dates is a question that's been raised with Parliament, and we'll wait until it's discussed in the oral hearings, and rather than me try and respond to it now. The bottom line is that massive systems reforms like this do not happen in short spaces of time. But you can make steps towards improving things in short spaces of time. And we are looking at the recommendations of the Health Market Inquiry to make improvements in the private space. We are looking at outcomes of the question was raised about the pilots. There were some things that the pilots told us definitely don't do them because they're either too complicated or they don't work. And there were some things that told us this might work, but you didn't do it in an integrated way with other interventions, so it lost its impact. So you can cautiously optimistic about a recommendation, but you need to do it differently. So we are busy defining these proof of concepts, integrated sub-district solutions, which are called CAPs. And there are a whole lot of unanswered questions about legal frameworks, statutory authorities, employment of the officials, how you bring the private and the public onto the same boards of, is it trustees or is it this or is it that, which we need to go and test. And we need to test our IT systems, because on paper and just in the public sector, they work. But they're not integrated everywhere. They're just in a few facilities. Now we've got to make them more integrated. We've got to integrate our quality improvement plans. We've got to roll out from the good facilities to those that are really struggling. We need partnerships between public and private facilities so that there's an exchange, as I mentioned just now, where a particular hospital might be overwhelmed in the public sector, and there may be private facilities that offer potential bed space or theatre space to dilute the pressure on the public sector. All those things need to be tested. So in terms of timelines, during the course of this year, we had hoped to get as far as getting the major systems functional. But all our resources have been sucked into COVID until the last 6 weeks. And in the last 6 weeks, we've pulled out what is missing in our operation, on our operational plan, and therefore our digital systems and support for the NHI specifically, not just for COVID. And although we've learned things about COVID, it's still got to be very specifically integrated. But we've made huge progress on the interoperability frameworks. There's the health information exchanges, both in the private and the public sector, are coming together very nicely. The data centers in place, the structure of the digital systems and the languages that are going to be used in the IT systems, so that you don't have to go and buy new software, that you can use your own, but it must be interoperable. All those things will be ready for people to engage with them in the start of the new year. Obviously, it's not compulsory because we don't have the NHI bill yet, so we don't have an NHI fund yet. But there's a lot of that is coming into place and is ready, and we must experiment with it. We do have some constraints, of course, that we have to stay within the Public Finance Management Act. We do have the current provincial functions have not changed. We don't have the DHMOs in place and so on. So this is experimental stuff, and we won't roll it out to the whole country until we know that it works in designated pilots. You can call them pilot sites. I call them proof of concepts because I want to check that they actually work. So yeah, there's a lot of work to be done, and we are going to make mistakes along the way, and we're going to have to be prepared to backtrack and change our minds before we formulate things into regulations and fix them.
Okay, thanks. So the last couple of minutes, I'll just take a few live questions. I'm sorry that I haven't been able to get to all the questions, but I mean, we can always make more opportunity for sharing, some of these questions, at least not on a live thing, if that's the way to go. I can see that, I think it's Dr. Karen Kafur has a hand up. I don't know if you want to ask a question. That's on the participant list. If you do you want to unmute yourself and ask? That might be a mistake. Otherwise, Dr. Samantha Fee, towards the bottom, asked if she could ask a question live. I'm not sure if she's able to hear me at the moment.
I can, Dan, and I would like to ask a question, if that's okay.
So we'll spotlight you now. You can start in the meantime, Sam. Do you want to just put your video on?
There we go.
Got you.
Good. Dr. Chris, thank you very, very much for your time this evening and for your succinct explanation. I think it answers a lot of questions for all of us in the private primary care sector. A passion of mine is the training of primary care doctors, which I think is as fractured as our primary care service delivery. And I just wonder, with regard to the accreditation, I'm sure there are all sorts of boxes that need to be ticked there, but I'd be interested to know what your team's requirement would be for accrediting primary care practitioners with regard to their postgraduate training in the delivery of primary care in this country is, because as such, we don't have a standardized or formal primary care training postgraduate setup. And I'd value your input on this point.
Okay, thanks very much. So as a practitioner, I have views, and as somebody who's working in the system, I understand what the constraints and the steps are. So let's start with those. The role players are our professional body, HPCSA, which registers us, and with our various boards and requirements. And we need to work together with them from the authorities, because we don't want to impinge on professional. That's what makes a profession, is we, the professionals, make the profession. So we need to make the HPCSA and the boards in the HPCSA work for us. And we don't all agree with, as professionals, what goes on there. The second thing is that we need to get working models. And the working models in rural Malamulele and Limpopo, or the Sikisiki in the Eastern Cape, compared with Soweto or Deep Sloot compared with Sandton, cannot be the same working model. The framework needs to cover the same thing. We need to make sure the clinical care is no different, but the way in which those practices are built into the system are likely to differ. So we need to test them. We can't just write a thing on paper and assume it's going to be okay. We need to do our best on the paper and then implement these things. So that's what I would like us to do next year, is to make sure that we have integrated models, not vertical things that says you as a GP must go and work in the clinic down the road or do it. That's not going to help us at all. As far as clinical standards are concerned, the practice, so what we call an establishment, in fact, in the law, has to be adjudicated by the Office of Health Standards Compliance. And at the moment, those standards that are set there are what we call establishment standards. They're very generic, and they're more designed for a hospital or a health center than they are for a private GP's practice. So there's a process that's going on. It's been going on for years, and it got stuck, and now we need to get it going again, where GP standards get designed with GPs. And we've been discussing with the Office of Health Standards Compliance and saying, this is your turf. We don't want to interfere with it from NHI, but we would like you to do this process and to engage with the Department of Health, not the NHI office, because we're the funding body, and to get a much better standard that GPs agree with. But of course, from one GP to the next, there will be disagreement, and there's going to be a point at which somebody draws a line and says, these are the standards, we're going to test these, we're going to move with these, and if they need to be changed, we'll change them later. So we don't have all the answers, and I'm going to be asked this question at the Family Practice Academy next week, I know, and what I'm saying to them in the Family Practice Academy is, work with us. Let's build something that works for us, and if it doesn't work, let's redo it until we're happy with it. I'm afraid I don't have a concrete answer for you.
Thanks, Dr. Crisp. I'd like to give Dr. Esra Confidence Maloko an opportunity to ask a question. She's raised a hand. Sorry, he raised a hand. Welcome.
Good evening, and thank you very much, Nick, for the good presentation. I've been listening to the discussions as we have them, and also having been watching the media around the discourse, the public discourse that is around the NHI at this point in time. It seems that we are, in many instances, repeating what we have been talking about in the last 10 years. Whether the NHI will be reality or other matters such as human resources and infrastructure. And as such, the debate is missing the main task of our time, which is the processing of the NHI bill, so that we can emerge with the necessary legal framework for the implementation of South Africa's official NHI policy. The bill that is currently before Parliament states it categorically that the purpose of the NHI Act is to establish and maintain a national health insurance fund in the Republic funded through the mandatory prepayment that aims to achieve sustainable and affordable universal health care to quality care services. I am of the opinion that South Africans should be focusing on the fund and funding as the main focus of the NHI bill and not the health system strengthening mechanisms. What is your view? Thank you.
Thank you very much, Confi. And yeah, I mean, that's obviously from my personal perspective and where I'm working in the system, the fund is the issue. And you are quite right. Without a statutory framework, we don't have a fund. But even with a statutory framework and the law established and the board appointed, if we don't have the systems to make it possible for us to identify benefits, identify providers, regulate those providers through certification and accreditation, make sure that we understand where the facilities are, so our master facilities index is there. Our provider index is linked to the professional council, so we know where all the nurses and doctors and physios and OTs and everybody are. If all of those systems are not talking and the patient record is not giving us coded information so that we can count what we're doing, pay for it, and make sure that we are achieving equity and solidarity, which are the objectives of the National Health Insurance, then having the bill is on its own not going to solve anything. So we need to do both. But at a selfish level, I agree with you. It's the health department's problem to fix the quality of the health system. But in practice, the NHI fund will collapse if we are unable to identify sufficient services that have enough quality to be certified and accredited. So it's in our mutual interest to make sure that quality is improved now during the process. But I guess you're asking what's happening with the bill. COVID messed up everything because we were finished with the public hearings of the National Assembly, the Portfolio Committee, and we were about to embark, or Parliament was about to embark on the public hearings for those who had requested permission for oral hearings. And only after that does the department get right of reply on whatever's raised to Parliament, and Parliament raises with the department. And then we've got to go through an NCOP process. So there are quite a lot of steps going before we get to a point where the Portfolio Committee recommends to Parliament, to the Speaker of Parliament, that they want to table the bill. And it's at that point where the opposition people stand up and say, we want to go to court, or we want to object, or we want to do this because we still don't like what's been amended. So I'm afraid that's still got to happen over the next few months. And we have heard that Parliament received 33,000 written comments. Many of them are very short and will be very quick to go through. But there are a number of very substantial comments, and many of them need to be taken very seriously. They're not just criticisms. Some of them are actually very constructive, and we need to engage with what people are saying about them. So that's Parliament must do that, and from the department, and certainly from me, who's now working as the consultant putting the machinery together, we won't interfere with that process until Parliament asks us to comment. But you are right, we need the statutory vehicle so that we can get on with it now. And we need the machinery, we need posts. So the Department of Health, the Minister has now approached the Minister of Public Service for an amendment to his organogram to establish the key components that will become the National Health Insurance Fund, and has advertised the post for the head of the National Health Insurance branch. And as soon as that's approved, then further posts will be advertised, and we'll be able to get some actuaries and public health specialists and other people specifically to work on the National Health Insurance details. So hopefully that helps to give some perspective on where we are on this. It is moving forward, but it's disappointingly slow. Thanks, Confi.
Dr. Crisp, I did, when I put out this, when I advertised this talk, I said that I was going to keep it till about 9:15 to 9:30. So I'd like to end it off soon. I mean, the reality is that we could go on of this for hours and hours and hours. This is a huge project, and I will say just a couple of words at the end, but just before I do that, I just would like to give you the opportunity, if there's anything closing that you'd like to say, perhaps some positive or encouraging words to the doctors. I mean, I think that there's a lot of positivity here, and it's great to have this opportunity to just, let you end off with a thought.
Well, thank you. First of all, thank you very much for the initiative and for approaching me and giving this opportunity. As I saw the numbers rising, they went up to about 400. I thought I was watching the American elections with the numbers moving up and down all the time. I want to say that during the work that I did from the end of last year and through COVID, I've got nothing but praise for the doctors that I've been working with. Quite big forums, quite a lot of engagement. People have disagreed, they've agreed, they've engaged through different forums, specialists, GPs, and so on, and it's been robust. We don't always agree, but the spirit in which it's been done, and especially now during COVID, I really, really have enjoyed the work. We have a lot of work to do. We don't have all the solutions. We have a direction. We know where we want to go. And if you can allow these kinds of forums where we can engage from time to time, and we'll do it around the country with other forums as well, it helps. And we don't address everything, but it does give us an opportunity to share what you don't normally see in the public discourse in 15 minutes on a News Africa or SA News channel or whatever. So thank you very much. I really appreciate the opportunity tonight.
Thank you, Dr. Chris. So firstly, just to reply to that, I really want to thank you for your time. As I said at the beginning, Dr. Chris spends a lot of his time at the moment just educating doctors, and I certainly think that that's a pivotal part of this project. And just on your point of engagement, I mean, I think that's the strength of this whole COVID time. If there's one thing we could get out of this, it's the fact that we've learned to talk to one another, and we need to talk to one another more and more. And of course, there will be things we don't agree on. And I mean, we might vehemently disagree with one another. But at the end of the day, it's only through engaging through these issues that we can achieve our way forward. I was actually very happy that as I saw this meeting go on, that I brought someone really strong from the public sector and really strong from the private sector onto the same platform here tonight, because I think that's what these kind of things achieve. So thank you very, very much for giving us this opportunity. And I mean, it's very commendable, the detail with which I've got documents in front of me, the detail with which you are planning this and going and really forging the way forward. I think that I would speak largely on behalf of many doctors who say that we really deeply understand the importance of, creating an equal, accessible, free in terms of, the offering at the time of need, healthcare system for the people of South Africa. And I think we'd all be behind that. And of course, a lot of doctors have reservations, but hopefully those will unpack and will be dealt with as we go forward. So it's encouraging. And I think that, we haven't been able to answer half the questions here, but the questions will continue and they'll grow as we go forward. So thanks to everybody for making the time to be here again. And we will look for the right opportunities to do the right things. So I wish you all a good night. And if there are further questions that you have, you're more than welcome to reply to the emails that you got about joining this, the reminders for joining this webinar. And I will forward those to Dr. Crisp and the Department of Health. And many thanks to Hasina Kathrada, who from the Department of Health, who put this together for us with Dr. Crisp. And I'm sure she'd be very willing to put that into a document that we could all learn from, just to learn what they're putting together. So thanks all and have a good night.
Thank you, Daniel. Good night.
Okay. Good night all.
Thank you so much.
Thank you.
Thank you.
Thank you very much.